Stress-induced cardiomyopathy, also known as Takotsubo cardiomyopathy or broken heart syndrome, is a condition characterized by temporary dysfunction of the heart muscle. It typically occurs in response to severe emotional or physical stress and can mimic the symptoms of a heart attack. The diagnosis of stress-induced cardiomyopathy is based on clinical presentation and specific diagnostic criteria. In this comprehensive script, we will delve into the clinical presentation, pathophysiology, role of catecholamines, excessive sympathetic stimulation, differences from acute myocardial infarction, cardiac imaging techniques, patterns of left ventricular dysfunction, neurogenic stunning and its neurological implications, potential complications and long-term sequelae, gender differences in prevalence and outcomes, the role of emotional and psychological stress, and pharmacological management strategies for stress-induced cardiomyopathy. Stress-induced cardiomyopathy commonly presents with symptoms similar to those of a heart attack, such as chest pain, shortness of breath, and palpitations. However, certain unique features can help differentiate between the two conditions. Diagnostic criteria include characteristic findings on electrocardiography, ECG, and imaging studies, as well as the absence of significant coronary artery disease. Stress-induced cardiomyopathy is believed to involve a complex interplay of factors, including catecholamine surge, microvascular dysfunction, and myocardial stunning. The release of excessive catecholamines during periods of stress can directly impact heart function, leading to the characteristic symptoms and abnormalities seen in this condition. Catecholamines, such as epinephrine and norepinephrine, play a crucial role in the development of stress-induced cardiomyopathy. They can cause direct toxic effects on cardiac myocytes, impair coronary microcirculation, and disrupt normal electrophysiological processes within the heart. Excessive sympathetic activation, often triggered by severe emotional or physical stress, has been implicated in the pathogenesis of stress-induced cardiomyopathy. Sympathetic overdrive can lead to increased heart rate, blood pressure, and contractility, all of which can contribute to the development and progression of this condition. Although stress-induced cardiomyopathy may mimic acute myocardial infarction in terms of clinical presentation, there are several key differences between these two cardiac conditions. These differences include the absence of significant coronary artery disease, reversible left ventricular dysfunction, and distinct patterns of ventricular involvement. Various cardiac imaging techniques, such as echocardiography and cardiac MRI, play a crucial role in diagnosing stress-induced cardiomyopathy and assessing its prognosis. These modalities enable the visualization of regional wall motion abnormalities, myocardial edema, and other structural changes that aid in the accurate diagnosis and monitoring of this condition. Stress-induced cardiomyopathy can manifest with different patterns of left ventricular dysfunction, including apical, midventricular, and basal variants. Each pattern presents unique challenges in terms of diagnosis, management, and prognostication. Stress-induced cardiomyopathy has been associated with neurological complications, including acute stroke, seizure, and altered mental status. These complications, collectively known as neurogenic stunning, highlight the close relationship between the heart and brain and emphasize the need for comprehensive evaluation and management. Despite being largely reversible, stress-induced cardiomyopathy can be associated with various complications and long-term sequelae. These include arrhythmias, heart failure, cardiogenic shock, and recurrence of the condition. Identifying and managing these potential complications is crucial for optimizing patient outcomes. Stress-induced cardiomyopathy has been observed to have a higher prevalence in postmenopausal women. Gender differences in hormonal factors, vasomotor reactivity, and genetic predisposition contribute to variations in the occurrence and outcomes of stress-induced cardiomyopathy between males and females. Emotional and psychological stressors, such as grief, anger, and severe anxiety, have been implicated as triggers for stress-induced cardiomyopathy. The intricate interaction between the autonomic nervous system, neuroendocrine factors, and emotional states plays a significant role in the pathophysiology of this condition. Current management strategies for stress-induced cardiomyopathy focus on supportive care and the prevention of complications. Medications like beta blockers, ACE inhibitors, and diuretics may be utilized in specific cases. Ongoing research aims to identify new pharmacological targets and interventions to improve outcomes in stress-induced cardiomyopathy. In conclusion, stress-induced cardiomyopathy is a fascinating and increasingly recognized condition that poses unique challenges in diagnosis, management, and prognostication. Understanding its clinical presentation, pathophysiological mechanisms, and associated complications is essential for providing optimal care to patients affected by this condition. Ongoing research and advancements in imaging techniques and pharmacological interventions hold promise for further improving outcomes in stress-induced cardiomyopathy.